Recording in progress.
Good afternoon, doctors. Wish you a warm welcome to this webinar series, Basics in Neurosciences, organized by Park Clinic and DG Neuro. This is episode 6, and the topic is how MRI works. This entire series is conceptualized by Dr. Sandeep Chatterjee and coordinated by Dr. Kaushik Seal. This initiative, digital initiative, is coming to you by Health and You, a joint venture with Newlink Company Limited, Japan. This series and host of webinars are available, more than 60, on our DG Neuro channel on YouTube, with 11 plus international speakers, 60 plus national speakers, and more than 1,000 hours of views. In epilepsy management, we have Brinda, Breveracetam, 25, 50, 75, 100. We were the first one to launch 2.5 milligram of clobazam, Adclobaz 2.5, 5, 10 in mouth dissolving tablet. In headache and migraine management, we were the first one to combine amitriptyline plus mecobalamin, amnurite 5, 10, and 25. We have launched a new concept, vitamin therapy for migraine, Brentamine, riboflavin 200, magnesium 200, and CoQ10, based on AN and American Headache Society recommendation. We were the first one to combine amitriptyline plus propranolol when one drug is not enough in migraine, amnurite beta 520 ER and 1040 ER, beat headache together. And recently we have launched in acute migraine, NDRAP, naproxen plus domperidone in a rapid acting formulation. Hydrophobic naproxen is covered with hydrophilic rapid acting particle to dissolve naproxen in just 30 minutes, 99% dissolution, rapid action, rapid relief. In neuropathy management, we have amnurite and amnurite P in moderate to severe neuropathy. Mecobalamin injection is imported from Japan to give you highest quality neurite injection, and neurite D in diabetic peripheral neuropathy. And for vertigo management, we have a specialist beta-histine. It's not beta-histine hydrochloride. It is beta-histine mesylate, 25% less strength to be given, mesylate 6 and 12, because less is more. That is what we have learned in at this pandemic. In stroke and post-stroke management, we have neurite active in hyperhomocystinemia, and in spasticity, we have Bacride, Baclofen, 10, 20 XR, 30 XR, extremely small tablet, and at 45% less price. So I have great pleasure now in handing over the session to Dr. Kaushik Seal, neurosurgeon for Park Clinic, to coordinate this session. Thank you very much. Dr. Seal, all yours.
Thank you, Deepakji. On behalf of Park Clinic, it is my honor and pleasure to invite you all to this webinar, the 16-hour series, and one of the most basic topics that we have is how MRI works. As you know, in neurosurgery, MRI is an integral part, and as neurosurgeons, we all see MRI, learn during our teaching curriculum how to interpret MRI. But actually, we do not get to learn the physics and the basics of MRI. Today, Dr. Sandeep Chatterjee, our honorable speaker, will be giving talk on this basics of MRI, how MRI works. Professor Sandeep Chatterjee is a academic coordinator, chief academic coordinator of Park Clinic. He is also the president of the Indian Society of Pediatric Neurosurgery, and he is a consultant at Park Clinic, Kolkata. And among the panelists, we have Dr. Shumita Kundu, a very respected radiologist of Calcutta, working at Eco MRI Center, Calcutta. Welcome, ma'am. And we also have as panelist Dr. Niloy বিশ্বাস. He is also a consultant neurosurgeon at Park Clinic. I don't know Niloy has joined or not, but he will join soon if he's not. And so, without any delay, it's over to you, sir, for your presentations.
Okay, well, good evening to everybody, and can you see me and can you hear me? You don't have to see me, you have to see the screen.
Yes, sir, we can hear you and we can see the screen, yes.
Okay, brilliant. If at any time you think you can't hear me, please do stop me, because the Wi-Fi's are so unpredictable these days that I don't know what happens. I have to begin with an apology. I've been asked to speak on MRI scan, how it works. And this is really not intended for people like Dr. Kundu. And I'm really, I have to apologize that she has to suffer this talk, because this is really meant for people who are in the basic stage of neurosciences training. I tell you why I like to give this talk. The reason is, when I was a resident, MRI came into this world. And of course, we had no clue what this was. We knew there was a magnet and we knew it produced pictures. And some of us volunteered to provide our necks and backs or our brains for them to calibrate the machines when it first came into the world. And I was a trainee in a center in the United Kingdom that first had an MRI. But I didn't understand anything about how it works. And words like T1 and T2 and proton density were fairly close to being Greek to me. So what the hell does an MRI do? How does it work, and how does it produce pictures? This is all that this talk seeks to cover. It's very basic. It does not seek to tell you anything about complicated sequences. I'm sure Dr. Shomita Kundu can take a lecture later on to tell you about all that. So here's where we start. And we start with the fact that 2 Nobel Prizes have been won. One perhaps a little wrongly, but 2 Nobel Prizes have been won en route to the discovery of the MRI. The first was these 2 individuals, Felix Bloch and Edward Purcell, who in 1946 were the first to point out that atomic nuclei absorb radio frequency energy, and then they can emit this energy later on. And in 1952, they shared the Nobel Prize in Physics. And they called this phenomenon NMR. N because it was a property of the nuclei of the atoms, magnetic because a magnetic field was required, and resonance because there was an interaction between the magnetic field and the radio frequency. And you will shortly understand what is meant by resonance. Of course, over the years, the name NMR, which was what it was called when it was first launched in the world, changed to MRI. And possibly the most likely explanation is people didn't like the word nuclear. So they were told, go and get a nuclear magnetic resonance imaging. They didn't like the word nuclear because it made them think of atomic bombs and radiation. And they thought, oh my God, we're not going through this investigation. So people got nervous and changed the name NMR to MRI. But in reality, the first 2 people that were able to set up a practical application of the phenomenon of NMR were these 2 people, Peter Mansfield and Paul Lauterbur, who were awarded the Nobel Prize in 2003 for their discovery of a machine that could use this physical phenomenon to produce images. I say there is a controversy because there is a controversy that maybe 2 other individuals got there before them who were denied the Nobel Prize for the same discovery. I'm going to talk very, very slowly in this lecture because this is really, as I said, meant for basics. And what's the basics? The basics is that you have a big magnet. You place a patient inside the magnet. You then send a radio wave in, which means an electromagnetic wave, which has the same wavelength as the radio waves. Then you turn the radio wave off. By the phenomenon of NMR described, the patient then emits a signal. This signal is picked up by the computer. This signal reproduces a picture, which people like Dr. Kundu looks at and tells us what's the problem with the patient's image. Let's go back to a little more about the basics. It's not a bad idea to remind ourselves that an atom consists of a nucleus, which has protons and neutrons, and outer orbits, which have electrons. and to remind ourselves that the body, which is composed mainly of water, has two hydrogen molecules, two hydrogen atoms and one oxygen atom in a water molecule. Hence, we can actually think of the body as consisting of a number of hydrogen atoms. And because the most important part of the hydrogen atom is the proton, we can think of the body as being composed of a number of protons. Now, if we take a body which is composed of a number of protons and put it in a magnetic field, then of course these protons align themselves in the direction of the magnetic field. So if you have a bar magnet and you put the bar magnet in a magnetic field, then the bar magnet takes up the alignment of the magnetic field. The difference with the proton is that some of them get into what's called a parallel state, which means they are in the direction of the magnetic field, and some of them go into what's called an anti-parallel state, which means they are against the direction of the magnetic field. And of course, those in the anti-parallel state are a little higher energy state than those in the parallel state. So if you add energy, shown here by delta E, to protons in the parallel state, they move into the anti-parallel state. That's too complex. To make it simple, protons either walk on their legs, which is obviously a low energy state, or walk on their hands, which is obviously a higher energy state. Those that walk on their legs are called in the parallel state. Those that walk on their hands are called in the anti-parallel state. And those that are in the parallel state are only slightly more than those in the anti-parallel state. That man sporting that t-shirt is not James Bond. He's got 007 there because for every 10 million protons that are in the anti-parallel state, walking on their hands, there will be 10,000,007 protons in the parallel state, i.e. walking on their legs. What does this mean? Before we come to that, let's try and understand that the protons are not lying static. They are in a motion which is called precession. And the best that I can tell you is this is the motion of precession, much like a swinging or spinning top. And of course, this precession has a frequency. And the way this everything works in an MRI is that there's the magnet, you're hitting the patient, there is an emission, you're picking that up and producing a picture, okay? And this precession frequency, which is the angular frequency of the proton moving in that peculiar motion, depends on the strength of the magnetic field, shown here as B0, and the gyromagnetic ratio, which is constant. Just as a matter of interest, the hydrogen proton, or the proton in the hydrogen atom, has a frequency of 42 millihertz. That means precession occurs 42 million times per second, which is pretty fast, and therefore not something you can photograph or record easily. And this equation, which connects the precessional frequency of protons to the magnetic field, is called the Larmor equation. Let's now try and work out the direction of the magnetic field. If you put a patient in the magnet, as shown in the diagram on the left, then the direction of the magnetic field is denoted as Z, with the two directions perpendicular to it in 3D, X and Y. So important to remember the direction of the magnetic field is Z. Now, of course, when you use the so-called 3D slicer MRIs, you can use either the LPS or the RAS technique. If you use LPS, that means you image from right to left, anterior to posterior, and inferior to superior. LPS standing for left, posterior, and superior. With RAS, you image from left to right, from posterior and to anterior, and from inferior to superior. RAS, right anterior superior. If you now look at the protons that are precessing, and you put the patient in the magnetic field, remember the direction is shown as Z, then it will be obvious to you that protons that are in the direction Z, which is in the parallel state, outnumber those that are in the opposite direction in the anti-parallel state, and produces a net magnetic vector in the direction of Z, as shown in the yellow arrow in the diagram. What about along the x-axis and in the y-axis? Well, along the x-axis, if you look at the images here, along the x-axis, if you have A, protons that are in the direction A, they are neutralized by protons in the direction A dash, so that there is no net magnetic field in the direction of the x-axis. If you look at the y, in the direction of the y-axis. If you look at the x, it's the same. If you look at protons like B and B dash, those that are in a position B are neutralized by those that are in the position B dash. So the fundamental point here is that because these protons are precessing in a random direction, the net magnetic field will only be in the direction Z. Now, if we are going to put a patient into a magnet, get the net magnetic field, and then say, okay, we've got a net magnetic field. Now we're going to measure the net magnetic field. And once we can measure this net magnetic field, we can get an idea of the images. Then how do we measure the magnetization? Because the measurement can only be done perpendicular to the magnetic field. It's like this old man sailing down the river who proceeds to take a pump and pour out water in the direction of the river. As the observer on the bank, you can see him pouring water into the river, but there is no way you can measure how much water he's pouring into the river because it's in the direction of the flow of the river. But if somehow he can be taught to turn around 90 degrees and pour that water onto the bank, as an observer, you can collect that water in a bucket like that, and that gives you an idea what is the amount of water that he's putting in the longitudinal direction. Hang on a second. This means that instead of having a magnetic field in the direction of the magnet, which is Z, if we can somehow turn that 90 degrees, then we get an idea of measuring that signal. So that's what we need to do in that machine. And the way we do it is by using what's called a radio frequency pulse frequency. Suppose you have two racing cars which are racing along side by side, and you want to pass on some energy. Here is a hamburger from one to the other. Well, it's only possible if they're side by side. If one is traveling faster than the other, then the picture on the right tells you what's going to happen to the hamburger. It will be with neither of the motorists. It will be in the middle of the track. So that's what you need to do. With an MRI, you need to get a radio frequency pulse, which will flip the direction of the magnetization from 90 degrees to transverse, the so-called 90 degrees flip. And how do we do it? By making sure that the two cars are moving at the same speed, read the same frequency. And that is the word resonance. That means if you have a radio frequency wave which has the same frequency as the frequency of the protons which are precessing, then this energy can be transferred from one to the other. So this RF pulse has to be in resonance with the frequency of the protons which are precessing, and then This is what it does. What does the radio frequency pulse do? It does two things. Number one, it makes, if you remember what we said, some of the protons that were walking on their legs go into a higher energy state and start walking on their hands, which means that the net direction of longitudinal magnetization, shown in yellow here, reduces to this. But it does something else. The radio frequency pulse is like the whip, which gets all these protons which were precessing in a random direction, which is why the Z was being cancelled from one direction to the other, and the X ones were being cancelled. And they now start moving in what we call sync. Bit like this. Here's a boat. The passengers are like the protons. They're randomly distributed across the axis of the boat, till such a time that a passenger spots a nice blue whale in one direction or the other. And of course, if it's a blue whale or a dolphin, then immediately the passengers all go onto one side and all become in sync in that transverse direction. This is exactly what happens to our protons. So instead of, once you give it a radio frequency wave, the longitudinal magnetization reduces, and you get gradually development of a transverse magnetization along the axis Y. And of course, you will remember this was the whole aim of the exercise, because we wanted a new transverse magnetization which we could now record or measure. So, what have we said so far? We said that when we take a patient and put him into the MRI machine, the protons will line up parallel or anti-parallel to that magnetic field in the direction Z. When we then send in an RF pulse, if this RF pulse is the same frequency as the precession frequency of the protons, or the RF pulse is in resonance with the protons, some protons pick up the energy, start to walk on their hands instead of the feet, and therefore, because they're pointing in the opposite direction, the longitudinal magnetization reduces gradually. The protons get into sync. They start to precess in phase, and the vectors add up in the transverse direction Y, and you start getting a transverse magnetization. So the purpose of the radio frequency pulse is to reduce the longitudinal magnetization and to start a transverse magnetization. Okay, what happens when you switch it off? Well, obviously the reverse happens. And as you switch it off, the transverse magnetization gradually reduces, because the protons are no longer in sync, which means gradually they start again precessing in a random direction. So the transverse magnetization reduces, because now they move from walking on their hands to walking on their feet. The protons that walk on their feet increase in numbers compared to those that are walking on their hands, and you start developing a longitudinal magnetization again. So this is what happens when the RF pulse is switched off. You start getting the longitudinal magnetization come back again. Okay, let's try and show this graphically. If we're going to plot the longitudinal magnetization after the RF pulse is switched on, we get a curve like this, where the longitudinal magnetization gradually increases back into its original value with time. And this curve is called the T1 curve. What happens if you plot the transverse magnetization? Obviously, the transverse magnetization, when you switched off the radio frequency pulse, was at its maximum. And this transverse magnetization also reduces with time, and you get a curve which is called the T2 curve. And it's important to understand that if one plots transverse magnetization of the RF after the RF pulse is switched on, this T2 curve that you get is actually much, much smaller or shorter than the T1 curve. One way of remembering this we'll come back to later. But it's important to get some definitions. The time, therefore, taken for longitudinal magnetization to return to normal, as shown on the T1 curve, is called the longitudinal relaxation time, or T1. The time taken for the transverse magnetization to disappear after the RF pulse has been switched off is called the transversal relaxation time, or T2. And as I've told you, if you couple T1 and T2 curve, the T1 curve is much longer in time than the T2 curve. An easier way of remembering this is if you have a mountaineer who is skiing, then it takes a long time for him to drag the ski up to the top of the mountain, lasts longer, that's the T1 curve, and a very short descent as he skis down the mountain slope rapidly, that's the T2 curve. So if the T1 curve can go from 300 to 2000 milliseconds, the T2 curve lasts from 30 to 150. And if you couple T1 with T2, this is what it would look like. So in reality, of course, it is difficult to pinpoint exactly when longitudinal magnetization comes back to its original value and when transverse relaxation ends. So instead, T1 has been defined as the time when about 63% of the original longitudinal magnetization is reached. And T2 is the time when the transverse magnetization decreases to 37% of the original value. And these percentages are derived from the equation 1 minus 1/3, which is 63%, and 1 upon E, which is 37%. So T1 is the time when 63% of the original longitudinal magnetization is reached. T2 is the time when the transverse magnetization decreases to 37% of its value. And the reciprocal of T1 and the reciprocal of T2 is called the longitudinal relaxation rate and the transverse relaxation rate. Enough of definitions. They don't help. But it's important to recollect that T1 can last from 300 to 1500 milliseconds, T2 from 30 to 150 milliseconds. Now you often hear about long relaxation times. What does that mean? To answer that question, let's go and visit this gentleman in his bar. Here's a man at the bar, and you go to that bar and tell him you want a long drink. So he takes the drink, he pours it in, he pours the ice, he holds the shaker in his hand like that, and it takes him quite a long time for him to get you a nice long drink. And it takes you a long time to drink that drink. So when you reach the stage that you're finishing the drink, you're the only man in the pub, and the poor bartender is looking at his watch to tell you it's closing time. I'm sorry to tell you that there is a curfew due to COVID and you have to finish. So if you want a long drink, it takes a long time to prepare it. It takes a long time to drink it, which means in magnetic words, liquids generally have a long T1 and a long T2. After the drink, if you're hungry and you want to rush to a fast food place, then of course you pay the money and you get your hamburger very quickly and you eat the hamburger equally quickly, which means that the fat has a short T1 and a short T2. Right. So liquids have a long T1 and a long T2. Fat has a short T1 and a short T2. What is it that influences T1 and T2? And we've already said T1 is longer than T2. Well, T1 varies with the strength of the magnetic field. It is longer in a stronger magnetic field. T2, remember, of water will be much longer than the T2 of impure liquids, which contain more molecules. So if you have pure water versus water which is contaminated, T2 of the pure water will be longer. Okay. Let's once more remember what the radio frequency pulse has done. Remember, after the radio frequency pulse, the number of protons in the high energy level equals the number of protons in the lower energy level. Longitudinal magnetization disappears. There is now phase coherence. That means all the protons are precessing in sync or phase. And therefore, what happens in the net result is what you've done is tilt the magnetic vector from the vertical to the transverse, from the Z to the Y axis. And this is called a 90-degree tilt. This radio frequency pulse, therefore, will be called a 90-degree pulse, because what it does is effectively changes the direction of the magnetic field from vertical to horizontal. And that's the concept of what's a 90-degree radio frequency pulse. Now, let's try and understand a little bit more about the 90-degree radio frequency pulse. Just to revise what we've said before. Before the RF pulse, it looks like what is happening in figure A. A longitudinal magnetization, nothing on the y-axis. After 90-degree pulse, all along the y-axis transversely, nothing along the x-axis. And then you switch off the RF pulse. Gradually, the transverse magnetization reduces and you get back your longitudinal magnetization by using the so-called 90-degree RF pulse. So before the RF pulse, there was only longitudinal magnetization. After the 90-degree pulse, there is only transverse magnetization. And after removal of the RF pulse, there is both, but gradually the longitudinal magnetization reappears and the transverse magnetization disappears. And if you plot the net vector, this is what it looks like a spiral. So this is the net effect of what happens in a 90-degree RF pulse when you switch it on and then proceed to switch it off. Now, if we are going to put a recording device, suppose this spiral has a bell, and we use a recording device to measure the sound from the bell by this device here, then obviously what will happen is you can get an electric current and you can get some vector inducing an electric current. This electric current will be the greatest immediately after the RF signal is switched off, and then it gradually reduces. This signal intensity with time graph is what's called the free induction decay. And although this is just put there for the purpose of completeness, this is not going to have a great impact on what we're going to say later on. Okay. Let's try now and understand what we mean by long and short TR. Consider two tissues here, A and B, with different relaxation time. Look at frame 0. Frame 0 here shows the situation with the two tissues immediately after a 90-degree pulse. So what happens? This is tilted 90 degrees by the 90-degree RF pulse. If we now wait a long time, this is called TR long, then gradually the longitudinal magnetization of both these tissues has been regained. And if we now use a second 90-degree RF pulse, so 90-degree RF pulse here, TR, time to repeat, the 90-degree RF pulse. So we use the time TR, time to repeat, before we give the second 90-degree pulse. Then the transverse magnetization of both are the same. Because here, they were the same. They gradually recovered at different speeds, so the two tissues. But when they both came back to normal, you used the second RF pulse and you recorded the same transverse magnetization. But hang on a second. If we don't wait for TR that long and TR is short and we send in a second RF pulse, when the two have recovered differently, so you will see the tissue A has a longitudinal magnetization that has recovered much more than tissue B, whose longitudinal magnetization has recovered much less. So your TR, or time to repeat the RF pulse, is short. Then now you can turn them around 90 degrees, record them, and you will get a difference in the transverse signal between these two tissues. What does this mean? It means that you can vary the time of your time to repeat, or the TR. And if your TR is long, you're not going to be able to distinguish between the signal from two different types of tissues. But if your TR is short, one tissue will regain more longitudinal magnetization than the other. And then when you give the second RF pulse, the transverse magnetization in one is much more than the other. So you will be able to understand the contrast of signals between the two tissues. Okay. So time to repeat, we said, was short or long. By definition, a short time to repeat is one which is less than 500 milliseconds. The long TR is one which is more than 1500 milliseconds. Now, let us look at brain and CSF. Brain has a much shorter longitudinal relaxation time than CSF. Now, if you are going to image brain and CSF together, and you use a short TR, then at this point, the signal intensities of the brain and CSF will differ much more. Whereas if you use a long TR along the graph, and this is measured, as you can see, of the longitudinal relaxation, then here, the difference between the two signal intensities will be much less. So if you use a short TR, you will be able to establish a much better contrast between the brain and CSF than if you use a long TR when their signals have become more or less the same. And of course, if we look at white matter, gray matter, and cerebrospinal fluid, then this is the sort of graph you get. You see, if you measure the time to generate the T1 weighted image, and the T1 weighted image, and you do it quickly, you will get a lot of contrast. If you do it with a long TR, you get much less contrast. And this is something that we will come back to later on. Let's get to another concept. The concept of what I call the race between the rabbit and the turtle. Suppose the rabbit and the turtle run in one direction for a certain length of time. Obviously, the turtle is way behind the rabbit or the hare. And then you say, okay, now stop. Turn around and come back. Then, of course, when they turn around and come back, at the time which is double the time at which you said stop and come back, both will be arriving at the starting point at the same time. Which means, if you, after a time, which we call half t or t by 2, tell the rabbit and the turtle to come back, then after another time, t by 2, they will both be back at the starting line at the same time. So if you have two buses, and you have singing passengers in the two buses, and the two buses with two football teams singing their song moves away from you. As the buses go further away from you, the signals vanish. And it vanishes due to extrinsic and intrinsic factors. Extrinsic factor is the speed of the bus. Intrinsic factor is the tiredness of the singers. Now, if you're going to try and compare the two signals, that's impossible. So after a time TE by 2, and the word E here stands for echo. So after a time TE, time to echo by 2, you tell the two buses to come back. And when after another time TE by 2, so if time TE, they're actually back, then of course you can compare the signal of the song between the two buses, because the extrinsic factors as far as the speed of the bus is concerned has been eliminated by bringing both the buses back to the starting point. And this is the fundamental concept of what's called a T2 weighted image. So after the RF pulse is switched off, remember the protons dephase. Now, once the protons dephase, they're no longer in sync. Now, if you give them a 180-degree pulse, you cause them again to rephase, but they precess in the opposite direction. So here we are. The protons were precessing after the RF pulse. At the point of time of switching off the RF pulse, they were all in this direction. When you switch them off, they become randomly distributed. Now, after a time TE by 2, if you give them a 180-degree pulse, after another interval of time TE by 2, they're back into sync, but they're pointing in the opposite direction. And this concept, it is what is called the spin-echo process. And we're going to explain that a little later again. So fundamentally, what are we doing? The 180-degree pulse refocuses the dephasing protons. It produces a stronger signal. This is called the spin echo. After a time TE, when you've given the 180-degree pulse at a time TE by 2. And if you draw a curve connecting the spin echo intensities, this curve is called the T2 curve. So the intensities were like this. If you connect them, then the curve you get is a T2 curve. So that's your T2 curve. Now, in a T2 curve, if you have, again, two contrasting material, let us say brain and CSF again, and you have a TE, time to echo, which is short, then both of them have a high signal, but the difference in signal or the difference in contrast between the two is small. Whereas if TE is long, the total signal intensity has come down, the T2 relaxation curve has come down, but the contrast is much more. So here again, with a T2 signal, if you have a short TE, you have less contrast, so the signals are higher, but with a longer TE, you get a much greater contrast between the two tissues, although the total signal strength here is less than what it is here. So the fundamental thing is, for imaging, we're constantly looking at the balance between having a good signal intensity and at the same time having a good contrast between tissues. So let us now just stop and review some of the things we've said before we carry on for the last bit. What have we learned? We've learned that a sequence, which is called a spin echo sequence, consists of a 90-degree pulse, which turns the longitudinal magnetization into a transverse magnetization, and then another 180-degree pulse, which turns that transverse magnetization in the opposite direction. After the 90-degree pulse, protons are dephasing due to various external and internal magnetic field inhomogeneities. The 180-degree pulse rephases the protons and serves to neutralize these inhomogeneities. And because the signals decrease from one echo to the next when you use multiple 180-degree pulses, this is what is called an internal T2 effect. Okay, let's go back and remember that when we say a short TR, we mean less than 500 milliseconds. When we say a long TR, we mean more than 1,500 milliseconds. When we say short TE, it's less than 30 milliseconds. When we say a long TE, it is more than 80 milliseconds. And if you remember, if we looked at the curve between pulse 1 and pulse 2, this is what you would get. And remember the pulse, the 180-degree pulse hits at a time TE by 2, and you record after double the time, so the time TE. Now, if you're going to use a 90-degree followed by a 180-degree pulse, this time when you start recording is called TE, the time to echo, and the 180-degree pulse has been used at a time TE by 2 after the 90-degree pulse. The image you now generate here is what's called a proton density image because it depends on the density of the protons. If you now give another 180-degree pulse and then record, then the image that you get is the T2 image. So let's try and see this a little more graphically. The moment you've given a 90-degree pulse, you've turned the the longitudinal magnetization transversal. Now, gradually this transverse magnetization, when you stop the 90-degree RF pulse, becomes random again. So now after a time TE by 2, you're giving a 180-degree pulse, and the 180-degree pulse starts getting them in sync again. And after a time TE, they're in sync again, but the transverse magnetization is now in the opposite direction. So what the 90-180-degree or the spin echo sequence does is it turns the magnetization first in this direction, then back to this direction with a stronger signal. And this is the spin echo sequence. And I say this so many times because this is something that we hear about all the time and that we definitely need to understand. Okay? Now, so the spin echo sequence, to summarize, consists of a 90-degree followed by a 180-degree pulse. The 90-degree pulse produces protons that are dephasing. The 180-degree pulse results in the echo and causes the transverse magnetization to tilt 180 degrees. Okay, look at some pictures from an MRI of one of our patients. Look at the TR 480, the TE 14. Look at this one, TR 3000, TE 92. So you will remember that when the TR is 3000, that means it's a long TR. And when the TE is 92, that's a long TE. And a long TR and a long TE produces, as we've said, a T2 weighted image. When the TR is 480 degrees, it's a short TR. When the T is 14, it's a short TE. And of course, a short TE and a short TR produces a T1 weighted image. So in fact, if you look at these figures that you're at the bottom of your MRI imaging and look at the time to repeat and the time to echo, without looking at the signals, you can still say, is this a T1 or a T2 weighted image? And this is how we're doing this. And we've said this so many times. I'm going to skip this and carry on. And carry on to something which is a little more exciting. Suppose we take the signal intensity of a tissue and we take its longitudinal relaxation graph and then on it superimpose the transverse relaxation graph. So in other words, this is your longitudinal relaxation curve. After a time TR, when you have the radio frequency pulse, remember the transverse relaxation will come down after the TR. And then after time TE, you can measure this. Then you get a curve which joins the longitudinal to the transverse relaxation. and the two curves join at the time TR on the time axis. Okay, so let's now try and understand what that means if you have two tissues. If you have two contrasting tissues, and we're going to talk about brain and CSF again, and if you have a long TR and a short TE, and you record here, then of course, what you see is differences. The differences in the T1 are no longer reflected. The differences on the T2 are no longer reflected. So because the differences in the T1 will be maximum here, the differences in the T2 between these two curves will be maximum here. But at this point, they have neither differences in T1 nor differences in T2. And of course, what you are going to record with images like this with a long TR and a short TE will depend on the density of the protons. Ideally, the TE should be close to 0, and what you get is called proton density images. So for a proton density image, the TR is long. That eliminates the difference between the T1 effects, and the TE is very short, which eliminates the difference between the T2 effects. So a long TR and a short TE produces a proton density image. If now, instead of if we have a long TR with a long TE, then of course we are no longer looking at the differences in T1 between the tissues, but we're looking at the difference between T2 curves of the two tissues. And this, where you have a long TR with a long TE, you produce what's called a T2 weighted image. It is obvious, therefore, if you have a short TR and a short TE, then of course you get images in here, and basically you get images which depend on the contrast between the weighted image has a short TR and a short TE. A T2 weighted image is a long TR and a long TE, and a proton density image has a long TR and a short TE. And this should now understand. Now, what happens if we have a very short TR and a very long TE? So you will get a very short TR and a very long TE. The signal between these is so small, you cannot record it. It will neither produce a T1 nor a T2 nor a PD effect. This is not going to produce any significant effect at all. So in brief, a long TR and a short TE produces a proton density image. A long TR and a long TE produces a T2 weighted image. And a short TR and a short TE produces a T1 weighted image. And of course, we know if you look at the images, what is the difference between fat and CSF, white matter and gray matter in each of these images, whether it's T1, whether it's proton density, or whether it's T2. For example, in T1, you can see fat is bright, CSF is dark, gray matter is dark, and white matter is light. In T2, fat is bright, CSF is almost as bright, gray is light, and white is dark, and PD is in between. And you can similarly get MR signal intensities of solid masses, cysts, acute and subacute bleeds, and work out what will be the signal intensities in each of these types. You can also understand that if you have two substances whose T1 curves are like this, but T2 curves intersect each other, then at this point, if you record, there is no difference between the signal intensities of these two substances, maybe brain and CSF again. But at this point, there will be a lot of difference, which depends on their T1. And at weighted region. And this, of course, is the region where there is no differencing signal between these two. I'm just going to end by telling you about two other things which may be of interest. One is what does the rare earth gadolinium do in terms of imaging? And I'm going to try and finish this off in the next 5 minutes because we don't want to take more than 50 minutes talking about this. Just to tell you that gadolinium is toxic and therefore it's used as a DTPA chelated compound. What does gadolinium do? It just shortens the relaxation time of the surrounding protons. What it effectively means is it shifts the T1 curve to the left. Aha, what does that mean? If you now have two substances, look at this. This is a tumor and this is brain. A is tumor, B is brain. You give gadolinium, then what happens? The tumor cells take up that gadolinium. It shifts the T1 curve to the left. What does that mean? That means at a point here, let us look at this point, TR. If your point here, TR, you were measuring the difference, difference in contrast between these two tissues, tumor and brain, would be very small. Well, once you've given gadolinium and the T1 curve of the tumor has shifted to the left, then at the point TR, the contrast between these two is significantly more. So what gadolinium does is it enhances the difference in contrast between the tissue that takes up this gadolinium and the surrounding tissue. In this case, the tumor and the brain. So gadolinium enters the tissue A, the tumor. The T1 of A becomes shorter. The T1 curve is shifted to the left. And at the time TR, the signal from this tissue is much more than it is here at time TR without gadolinium. And because this tissue B does not take the gadolinium, the difference in contrast between the two is significant. Just to tell you, in addition to spin-echo sequence, you can have what's called an inversion recovery sequence. And this is basically that you give the 180-degree pulse first and the 90-degree pulse later. And we're not going to go into details of this. I just want to end with one last concept, and the concept of how you get angiograms in MRI. This is something that intrigued me when I first started seeing MRI pictures in the sort of mid-80s or late 80s. How do you get an angiogram without any contrast? And this depends on the concept of the so-called flow void. And I'm just going to show you this very simply. Here is the tissue around the blood vessel. Let us take this block of tissues A, where there's blood flowing. The protons in the blood are orientated like this. The protons in the tissue around are orientated like this, as shown in the diagram A. You now give your 90-degree pulse along this section. The proton in that section inside the blood vessel and those outside are both turned transverse. You know, a 90-degree pulse tilts the proton, tilts the magnetization 90 degrees. So we have this situation. Now, if you use another 90-degree pulse after this to try and again re-record, what's happened? This blood, which had this transverse magnetization, has now moved out. It's no longer in this. So when you do give another 90-degree pulse, the tissues outside the blood vessels have become like this because their vertical magnetization is small. But the tissue here is the blood that has flowed in from here. It was not subject to the transverse magnetization. That bit's gone outside the range of your 90-degree pulse. So you get a much bigger signal from this new bit of blood that has come into this particular rectangle, because the bit that was here, which had the same signal as here, the surrounding tissue has now flowed on to here. So you get a much bigger contrast of the blood here compared to the tissues around. And this is the concept of the so-called flow and signal and its use in MR angiography. Just to tell you, can we use other nucleus for imaging, not hydrogen alone? Yes, you can. And finally, if we look at the hardware, you know that the magnetic strength is calculated in Tesla, named after Professor Tesla, who was a very strange man. because Professor Tesla, in fact, was one of the few individuals, if not the only individual in history, to have refused a Nobel Prize. He was offered a Nobel Prize jointly with Thomas Alva Edison, and he refused it. And of course, it's after him that the magnetic strength is named. 1 Tesla is the same as 10,000 Gauss. Just to tell you, the MRI looks like this, but this is the hardware that's inside. You got a magnet, gradient coils, the RF coils all around the patient. You have an RF detector. You have a gradient AMP and a gradient pulse program, a digit. Field. These magnets get very hot and they need to be cooled. And then, of course, you have the superconducting magnets, which have current carrying conductors cooled to superconducting temperatures. This is what is used in MR machines today. And of course, you have coils, which could be the volume coils, which are the body coils, the shim coils, which are used to achieve magnetic homogeneity. And you have gradient coils and surface coils, and I'm not going to go into the details. And all this is put into this sort of a thing called a Faraday cage. So this says to be continued, because if you now want to learn about more techniques, then you have to hear the second, more complex phase of this talk. But till then, I think this is enough to try and understand the basic working of an MRI for one day. So thank you very much for your attention. And I'm very glad for Shomita to tell me all the wrong things that I've said. And I'm sure she can make things a lot simpler and easier than I've tried to make it.
You have made a really great presentation, I think.
So we would invite comments from Shomita and Niloy about how an MRI works. Does it make it any simpler, do you think, for students who are looking at this for the first time?
As you rightly said, I think the entire progress of neurosurgery now is largely because of the progress made in imaging. Apart from the gadgets we use in the OT, now one important thing in brain pathology, we don't have the provision to take biopsy always. So we have to depend on imaging a lot to get an idea of what the pathology is. So it's very important for neurosurgeons to know what the sequences are. For sometimes you have to ask for those sequences. If you don't know yourself that what sequence will show you better, whether it's a fat suppression images you want. So these are very important as a neurosurgeon to have a basic idea of what sequence shows what pathology is best, so that you can, while just writing an MRI simply, you can write that I want this sequence because I am suspecting these things. So this is very important for we as neurosurgeons. Second, as in terms of operative planning also, I think the newer the MRI sequences like DTIs, the functional imaging, all these has changed our operative planning and everything. So that's what I feel that as a neurosurgeon, we should know at least a basic idea about how an MRI works and what are the different sequences.
So when I said to be continued, I thought that was because I expect that Dr. Kundu will one day enlighten us a little more and tell us a little more about what these various sequences are. I had great trouble trying to understand it, and I never found it easy because whenever we got a radiologist who was very well informed, they started off with things that I never understood a word of. And I thought, what the hell is this RF pulse in the first place? And what's an inversion sequence? Why do you say spin echo? So, I mean, this is just to try and make people understand the concept of what is echo, why spin, what spins, and of course, just a very basic concept of what does T1 and what does T2 curves mean, and why do you give gadolinium, and where do you get the contrast, etc. So that at least as surgeons, we are a little aware that we try and understand a little bit. We can never understand what the radiologists understand because they're very intelligent people, unlike us.
Yes.
but we need to try and understand a little bit about what we're talking about. And that's the idea of this talk. This is, as I said, I apologize to Dr. Kundu because it's not meant for her. It's meant for people like me who are struggling to understand the nuances of what the hell this MRI does.
Well, I would say that you had made a really nice presentation, explained very well. And, throughout my experience from my medical postgraduate days, I have found that you need to keep on repeating and to understand what is exactly the basic MR physics. Because once you hear a lecture or you read something, you're bound to forget it after some time. So it's very nice to have, repeated lectures and to listen to something like a presentation which you made just now. And today, what I would like to say is MR has developed so much, the basic we should not forget. But on top of that, the sequences have changed very much. We now have a variety of sequences and each vendor has his own. They have their own names. So we have to stick to the basics and then think about the other sequences. And another thing which I would like to say, what Dr. Nilay Biswas was saying, for a particular ailment, if you just write, say, for instance, dementia protocol, stroke protocol, then those things, all the sequences will be taken by the people who are doing the scanning. So if you want anything particular, you can just write it down. Like a dementia protocol will include an SWI, a TWI, so you will get all that. If you want a tumor protocol, you'll get an MR spectroscopy, a perfusion, all those things. Only thing, the cost goes up a bit. That's all.
Now, one of the big problems that we have, at least which I have as surgeons, is that, each company uses their own terminology.
Yes.
So, say something like Fiesta or Fiesta C. This is a GE terminology that GE started for their machines. And trying to understand the difference between Fiesta and Fiesta C was a nightmare for me to try and work out what the hell is the difference between the two. And of course, it is the sequence of choice. If you're doing a cysternography, for example, you want to see cranial nerves at the skull base, and what I understand, that gives you a very good depiction of the same. But each company making its own nomenclature makes it very difficult for us to try and follow. Why don't we have a universal system of nomenclature rather than allowing each one to make his own names?
It's one-upmanship between the companies. Each one says that my sequence is a better one than yours. So that's the problem. Basically, they use the same kind of sequences. They only give them different names, or maybe some minor variations may be there. But we can't really tell the companies what to do. They do it on their own research and development programs. So
I'm going to ask you one last question, which I always ask, and I think you're going to tell me about it, is just two questions. Number one, what would be the best sequence if we're trying to see CSF flow? Say, because this is what, as neurosurgeons, particularly pediatric neurosurgeons, we are obsessed about. Is there a way we can look at a shunt tube and say, by imaging an MRI, I can tell you that there is flow of CSF through that tube? I don't mean flow through the aqueduct or flow through the fourth ventricle. I want, is there a way we can do a sequence and say there is flow through a tube of a shunt? Because it makes a huge difference.
Yes, we can use the phase contrast sequence like we do in the aqueductal CSF flowmetry, and the angle of the planning should be perpendicular to the area of flow, so that we can measure if there is any flowing CSF through it, same as how we do in the aqueduct. Only thing is the rate of flow may not be very high. If it is blocked, then we won't be able to see any signal alteration. If the flow is sufficient, then we will be able to see signal alteration in the flowing CSF in systole and diastole. That we can do, but the angle has to be correct.
And last question, Fiesta with conventional MRI, Is that the best thing to ask for if you're looking at a brachial plexus traumatic injury and we want to see what the situation is with the nerves?
Now, brachial plexus, you can see beautifully with diffusion weighted images, space images with fat suppression, space with contrast. You can get beautiful images, and even diffusion is routinely done, as well as MR myelography to see any pseudomeningocele avulsion injuries of the nerve roots. So brachial plexus has its own a lot of sequences which have been developed.
Trying to keep a track of all this is very difficult for simple neurosurgeons.
Neurosurgeons are never simple. They do the most complex things.
You see, I'm going to end telling you, Shomita, what I've been told by my wife for years, that neurosurgeons are different from all other doctors because they require one brain, and that's the brain of their patient, unfortunately. Right, I think, Kaushik, all yours. Are you here?
So we have some questions in the chat box.
Go on. So there's a question which says, I'm going to deflect this to Dr. Kundu, which says, which Tesla is better? What does that mean? I really don't understand what that means. Which Tesla is better? So I think what they mean to say, what is the strength of the magnet that would be ideal for use?
Yes, for neuroimaging, a 3 Tesla magnet, which is currently the most widely used magnet in neuroimaging, would be the best. Of course, you can try higher end images with 5 Tesla, 7 Tesla, but those are mainly used for sort of research purposes. For routine clinical imaging, a 3 Tesla high-end equipment would be the best.
7 Tesla are the ones that make you deaf once you have those sort of scans.
No, they do it very carefully, and I think they take all the precautions.
Okay, the second question was, I'm not going to understand what the questioner wants, but he says, what's the role of MR imaging in an autistic child?
Okay, we do get autistic children referred to us for MR imaging. Most of the patients we generally find a normal brain, but you can get anomalies like Vermean hypoplasia, you can get ventriculomegaly, you can get white matter changes, but there is nothing which will say from an MR that this is a pinpoint towards an autistic child. We can only say that these are the brain changes which have occurred. And very often, most of the children which we get, they just have normal brains. So occasionally, basal ganglia changes have also been seen. But there is nothing which is absolutely a pointer towards an autism. You get this autistic spectrum disorder children, but very often they don't have much changes, but they can have brain structural changes as well as white matter changes.
Yeah, I think the other very interesting thing that's been done with autistic children, of course, is the functional MRI, looking at the connectivity of children with low verbal or cognitive performance. And very interesting studies have come out of what the functional MRI shows in these children.
And
but this is
now,
more research.
Yeah. And now, you know, these neuro centers which are focused on neuroimaging, like NIMHANS, etc., they do resting state MRI, which is much easier to perform on psychologically disabled or even children, because they don't really have to do anything. They just have to lie still, and it is a sort of a non-active fMRI. And you can get these connectivity disorders seen very well by them. But that's also only in very select institutes, not in general places where routine imaging is being done.
Yeah, I mean, and I think really what the questioner is asking and refers to is the fact that nowadays a lot of people think that with functional MRI, you can look at connectivity in the brain as a guide to prognosis of autistic children. If you can look at the connectivity networks, you get an idea of what sort of what to expect in future in terms of development. And what do you expect in terms of IQ score?
The resting state fMRI helps in doing that.
Fantastic. Any other? I think I've got all the questions in the chat box. I think, Kaushik, are you still there, or is Kaushik started operating? So if he has, I think we'll gently bring this to a close. And on behalf of Park Clinic and in the absence of my colleague who's had to start an emergency surgical procedure, I would like to thank all of you who have checked into this and give my particular thanks to Dr. Kundu, who is without doubt one of the busiest radiologists in this city, also one of the most informed ones. And therefore, we would like to really thank her for spending an hour and 15 minutes of her time to hear some basic trash about MRI. So thank you very much for being with us. And Dr. Niloy বিশ্বাস also, as you can see, is in between operations. He's a very busy surgeon who operates all day and most of the night. And he's in between cases and he's also spared his time to be with us. So thank you, Niloy. Hand you over to Deepak.
Thank you.
Thank you very much.
Thank you, sir. It was a very, very interesting session and you made it very easy by a lot of illustrations. And therefore, 147 participants participated in this program. We would like to thank all the participants. As Dr. Chatterjee said, it is a busy day. At 4 o'clock, neurosurgeons find it still busy and the operations are going on. But still 147 audience we got. We would like to thank the speaker, Dr. Sandip Chatterjee, the panel member, Dr. Sumita Kundu, Chief Radiologist of Texore, Kolkata, and Dr. Niloy Biswas, Neurosurgeon of Park Clinic, Kolkata. This is Deepak Naik. Would like to thank all of you on behalf of Health and You. Signing off with a commitment that we'll be back with the 7th episode of this series, Basics in Neurosciences. Till then, goodbye. Thanks a lot.
Thank you. Thank you very much.
Thank you.
Thank you.
Recording stopped.